and positron emission tomography in the assessment of patients with cardiovascular disease. Introduction. Nuclear cardiology involves the imaging of cardiac radiopharmaceutical distribution to characterize physiological and pathophysiological processes in the heart. The ability to image myocardial perfusion and metabolism non-invasively with nuclear techniques has led to the development of a field that has been validated extensively and provides powerful diagnostic and prognostic information in the management of patients with known or suspected CAD. Moreover, nuclear cardiology procedures have been employed widely in the evaluation of patients prior to cardiac and non-cardiac surgery. This chapter provides an overview of the concepts and techniques used in nuclear cardiology and summarizes its role in the assessment of patients with stable CAD and acute coronary syndromes and in the determination of myocardial viability in patients considered for revascularization. As a complete discussion of the technical and procedural aspects of nuclear cardiology is beyond the scope of this chapter, the central focus will be on the utilization of nuclear cardiology in patients with known or suspected CAD, with an emphasis on patients undergoing cardiac surgery. For a more detailed discussion, the reader is referred to other more comprehensive reviews. General principles. Nuclear cardiology has been dominated by radionuclide myocardial perfusion imaging, MPI, as a means to evaluate patients with known or suspected CAD. Myocardial perfusion imaging is performed to evaluate diagnostically patients with symptoms suggestive of myocardial ischemia and to risk stratify patients with known CAD. Radionuclide MPI plays a central role in the evaluation of the cardiac patient and is in widespread clinical use, with more than 5 million myocardial perfusion imaging procedures performed in the U.S. annually. Myocardial perfusion is governed during resting conditions by the coronary resistance vessels. During periods of increased work, as during exercise, flow is increased to balance the metabolic demands of the myocardium. This is achieved by vasodilation of precapillary arterioles, which reduces vascular resistance in the coronary arterial bed. In stenotic, atherosclerotic coronary arteries, resting flow is maintained by decreasing downstream vascular resistance. While this compensation maintains flow under resting conditions, a significant stenosis, 50 to 70% narrowing of the lumen, impairs coronary flow reserve, or the ability of the artery to increase flow appropriately during periods of increased demand. Radioactive tracers. Myocardial perfusion is imaged with the use of radiopharmaceuticals that accumulate rapidly in the myocardium in proportion to myocardial blood flow. The most commonly used radiotracers currently are the technetium-99m labeled 99MTC, compound sestamine and tetraphosmin, and, to a lesser extent, thallium-201TL. When injected these tracers are extracted from the blood pool and accumulate in cells, including myocytes, that have an intact cell membrane and are metabolically active. 99MTC sestamine and tetraphosmin are lipophilic cationic complexes that are taken up by myocytes across mitochondrial membranes, but at equilibrium are retained within the mitochondria because of a large negative transmembrane potential. Thallium-201TL is transported like potassium across the myocyte sarcolemmal membrane, via the NOPLAS-K-plasmid-based transport system. Because the retention of radiotracer is proportional to myocardial flow, the amount of tracer uptake is a surrogate visualized representation of regional myocardial perfusion. The tracers used are radioactive isotopes that undergo radioactive decay over a short period of time. Equipment and procedures. As the accumulated radiotracer decays, photons are emitted that exit the body and can be detected using a specialized gamma camera. Myocardial perfusion imaging employs the use of single photon emission, SPECT, techniques to acquire and ultimately display the perfusion distribution obtained from the radiotracer uptake. After the radiopharmaceutical is injected, the patient lies supine on the SPECT camera table and is positioned in the gantry of the camera. As the camera detector moves around the patient, emitted photons interact with the camera's crystal and produce scintillations of light that represent the spatial distribution of radioactivity in the patient. The emitted counts localized to each region of the myocardium are then stored digitally. This 3D representation of myocardial perfusion is then processed and reconstructed using computer algorithms to display the acquired information in a series of slices, oriented in the short axis and horizontal and vertical long axis of the LV. The slices are then displayed on a computer screen for visual inspection of regional myocardial perfusion as well as computer quantification of tracer uptake. The stress images, acquired after injection of radiotracer during exercise or pharmacological stress, are displayed adjacent to images acquired at rest, permitting direct comparison of perfusion in the two imaging states. The maximum uptake of radiotracer in the heart is used to represent normal perfusion, and the rest of the myocardial counts are considered as relative uptake to this maximum. A regional perfusion defect on the stress images that is not present on the resting study is considered to be reversible and consistent with stress-induced ischemia in that vascular territory. A defect that persists on stress and rest is deemed fixed and representative of scar prior myocardial infarction. Quantitative programs are commonly used to assess the extent and severity of each defect, which is then incorporated into the final interpretation of regional myocardial perfusion. The perfusion images are also obtained in concert with ECG gating, which stores the counts with respect to the timing of the cardiac cycle. By gating the acquisition to the RR interval of the ECG, images from each frame can be summed and displayed as a movie of the LV contracting from diastole to systole. Performing gated SPECT facilitates measurement of left ventricular ejection fraction and LV volumes by automated computer algorithms, as well as visual inspection of the movie for regional wall motion and thickening. Figure 56-2. Figure 56-1, SPECT myocardial perfusion imaging. Visual display of SPECT myocardial perfusion imaging with stress study above the rest study for comparison. Each panel contains 3 representations of the same imaging procedure, each oriented differently. Short axis slices from apex to mid-ventricle and mid-ventricle to base, top. Vertical long axis slices from septum to lateral wall, middle, and horizontal long axis slices from inferior to anterior wall, bottom. A. The first set of images is a normal study in Gray scale with uniform uptake of radiotracer on stress and rest. Figure 56-1, SPECT myocardial perfusion imaging. B. A color-enhanced study. Review of the stress images demonstrates a perfusion defect in the anterolateral wall as evidenced by less radiotracer accumulation relative to other regions of the LV. As the corresponding rest images show normal perfusion throughout the myocardium, the perfusion defect is considered. Figure 56-1 SPECT myocardial perfusion imaging. C. The SPECT images demonstrate large perfusion defects in the anteroseptal, inforoseptal, and apical regions, which are present on both the stress and rest images. Because these defects do not show any change from stress to rest, they are termed fixed defects, consistent with scar prior myocardial infarction. Figure 56-2, gated SPECT still frame images of diastole and systole. During SPECT image acquisition, the acquired images can be stored in relation to the cardiac cycle using the RR interval of the ECG. The resulting images that are gated to the cardiac cycle can then be viewed as a sine loop from diastole to systole. Moreover, these data can be used to calculate LV volumes during diastole and systole, as well as the corresponding LVEF, diastole-systole. A typical SPECT myocardial perfusion imaging protocol involves the performance of exercise, typically on a treadmill or bicycle, or with a pharmacological stressor, such as adenosine, dipyridamole, or dobutamine in patients unable to perform physical exercise. The radiotracer is injected at peak stress and the stressor is then continued for an additional 1 to 2 minutes to maximize myocardial extraction of the circulating tracer. Imaging is performed 30 to 60 minutes later for sestamine or tetraphosmin, since these agents have only minimal redistribution or washout from the myocardium. The initial imaging can be either at rest or at stress, and both studies can be performed on the same day. Although thallium-201-TL is used less commonly for stress myocardial perfusion imaging MPI, it is commonly used for rest imaging in a dual isotope protocol. In this protocol, thallium-201-TL is injected for resting imaging, which is then followed immediately by stress perfusion imaging with 99 mTC agent, thus obviating the need to wait 2 to 3 hours for the first dose to decay. As such, imaging time is reduced and patient throughput is increased. Stable CAD, diagnosis and risk stratification. Stress testing in the detection of CAD. Nuclear cardiology is a central part of the evaluation of patients with suspected or proven CAD. The ability of SPECT myocardial perfusion imaging to detect CAD in patients with symptoms suggestive of IHD has been validated extensively. Exercise stress testing. Exercise stress testing without adjunct non-invasive imaging is frequently used as the initial screening test in patients without known CAD who present with chest pain syndromes or symptoms suggestive of ischemia. The premise of exercise stress testing is that the increased myocardial O2 demand during exercise will produce clinical signs of ischemia, angina, ECG changes, in the setting of a flow-limiting stenosis that impairs myocardial blood supply. The diagnostic performance of this test varies greatly depending on the pre-test likelihood of the population being studied. In patients with an intermediate pre-test probability of CAD on the basis of symptoms and risk factors, exercise treadmill testing is useful as an initial screening test. However, the overall sensitivity of treadmill exercise testing is approximately 70%. A meta-analysis of greater than 24,000 patients undergoing exercise stress testing and coronary angiography observed a mean sensitivity of 68% and a mean specificity of 77%. Accuracy was greatest in patients with multivessel CAD and those with LM or 3VD. Exercise stress myocardial perfusion imaging. Because exercise treadmill testing relies on changes in the 12-lead ECG as a surrogate of ischemia, the accuracy of the test is highly dependent on the baseline ECG. Abnormalities as previous MI, Q waves or LVBB, or street T wave changes due to LV hypertrophy or therapy with digoxin hamper the ability to interpret ischemic changes accurately during exercise. In patients with an abnormal ECG, myocardial perfusion imaging adds significant diagnostic accuracy to the treadmill test for detecting CAD. Numerous studies have consistently shown that SPECT myocardial perfusion imaging with technetium-labeled agents, as sestamib, yields a greater than 90% sensitivity for the detection of CAD. False negative scans tend to occur in the setting of single VD, particularly in the LCX artery distribution, a mild degree of stenosis 70%, or when the patient is unable to achieve the target HR or is taking antianginal therapy. These studies have also observed that the specificity of stress SPECT imaging is in the range of 68%. The less optimal specificity can be attributed to both referral bias, performing angiography in only those patients with abnormal scans, as well as false positive scans with defects due to artifacts produced by soft tissue attenuation, diaphragm, breast, or patient motion. Contemporary imaging techniques that employ ECG gating have facilitated the simultaneous assessment of myocardial perfusion and function. Examination of regional wall motion and thickening enhances the evaluation of a suspect area of hypoperfusion by providing the ability to distinguish true myocardial scarring from attenuation. More recent technical advances such as attenuation correction hold promise in further improving the specificity of SPECT myocardial perfusion imaging. Pharmacological stress myocardial perfusion imaging, MPI. As many patients are unable to perform physical exercise to a workload adequate for a diagnostic exercise stress test, myocardial perfusion imaging performed after pharmacological stress is used frequently as an alternative. This is typically performed after the IV infusion of a vasodilator, as dipyridamole or adenosine, or with the inotrope dobutamine. Dipyridamole stimulates the release of endogenous adenosine in the distal coronary vasculature, which then binds adenosine receptors in the vasculature, producing the desired effect of coronary artery vasodilation, as well as undesirable effects as flushing, bronchospasm, headache, and even transient heart block. This vasodilation of the resistance vessels increases myocardial blood flow, mimicking the effects of physical exercise. Dipyridamole is typically administered IV as a bolus injection over 4 minutes with peak effect occurring at 8 minutes, at which time the radiotracer is injected. a 4 to 6 minute continuous infusion of IV adenosine is now used more commonly. Both agents are equally effective in increasing myocardial blood flow 3 to 5-fold over rest, which is similar to that produced by exercise. However, adenosine tends to achieve maximal flow in more patients than dipyridamole. In short-lived side effects, hypotension, AV block, chest pain, and flushing are more common with adenosine than dipyridamole. An IV infusion of dobutamine is also effective for pharmacological stress. It is typically used as an alternative to vasodilator stress in patients with bronchospasm and pulmonary disease. The dobutamine infusion produces increased myocardial O2 demand by increasing HR, BP, and myocardial contractility. All of the currently used pharmacological stress agents have similar ability to produce flow heterogeneity and corresponding perfusion defects in the presence of a significant 50 to 70% stenosis of a coronary artery. A meta-analysis of dipyridamole SPECT imaging demonstrated a sensitivity of 89% and specificity of 65% for the detection of CAD. Dipyridamole and adenosine tests had essentially similar sensitivities and specificities. The sensitivity of dobutamine SPECT imaging to detect CAD is about 80%, which is slightly lower than that of the vasodilator agents. Several novel agents designed to bind specifically to the adenosine A2 receptors responsible for coronary artery vasodilation are currently under investigation. Preliminary data suggest that these A2 receptor agonists may selectively increase coronary blood flow without producing the side effects described previously. Prognosis and risk stratification. Stable angina. The goals of stress testing extend beyond the detection of CAD alone. For stress testing information to be useful, results must reliably identify patients of sufficiently low risk that further evaluation or intervention can be safely avoided, while also providing additional information to the clinical risk assessment when results are abnormal. The ability of both exercise and pharmacological myocardial perfusion imaging MPI to add incremental prognostic information to the clinical risk assessment in patients with known CAD has been evaluated in thousands of patients. Several large studies of patients with known or suspected CAD, including men and women, have demonstrated the incremental prognostic value of a normal myocardial perfusion imaging, MPI. Perhaps of greatest clinical utility is that these studies have consistently shown that patients with normal MPI have a subsequent annual rate of cardiac death and non-fatal MI of 1%, even in patients with known CAD. When the results are abnormal, the SPECT scan provides incremental prognostic information beyond that obtained by clinical, ECG, and stress testing combined. Moreover, the value of SPECT-MPI in determining prognosis is such that the information obtained from subsequent coronary angiography does not provide any incremental prognostic information beyond that obtained by the SPECT results alone. The increase in the risk of heart events increases in proportion to the severity and extent of the perfusion defect when assessed by semi-quantitative methods or automated quantitative approaches. The degree of ischemia on SPECT is associated with an increase in the short-term incidence of non-fatal MI, while scar size is more predictive of cardiac death. Other important stress MPI variables that are predictive of future cardiac events are listed in box 56-1. The prognostic ability of stress MPI is also enhanced by inclusion of ECG-gated SPECT, which permits assessment of LV global systolic performance, the most potent predictor of event-free survival, as well as analysis of regional wall motion. Box 56-1. Stress testing variables associated with worse prognosis. Perfusion parameters. Multivessel disease pattern. Large reversible, ischemic, defect. Large scar greater than 14% of LV. Transient LV dilation with stress. RV uptake. Resting LV dysfunction. Pulmonary uptake of 201 TL. Non-perfusion parameters. Poor exercise capacity. Angina at low workload. Dynamic street segment depression. 3 mm with exercise. Exercise-induced ventricular arrhythmias. Vasodilator stress-induced street segment depression. 1 mm. Hypotensive BP response. Medical therapy versus revascularization. One of the most important contributions of stress MPI in the clinical evaluation of patients with known or suspected CAD is the ability to provide prognostic information that can be used to guide testing and therapies. Because the extent and severity of ischemia on a stress MPI study is directly proportional to the risk of future cardiac events, this information can be incorporated into the decision-making process concerning medical or revascularization therapies for a given patient. Patients with mild ischemic defects that are not high risk generally can be safely treated medically, while those with high risk findings should be strongly considered for more invasive evaluation with a lower threshold for revascularization. A 3-year follow-up study of patients with mild to moderate defects on stress SPECT myocardial perfusion imaging treated with medical therapy noted a 2% incidence of cardiac death or non-fatal MI and 5% rate of revascularization, suggesting that SPECT imaging is highly useful in selecting patients with CAD at a sufficiently low risk for events such that revascularization is not necessary. In contrast, the benefit of revascularization over medical therapy has been characterized in patients with high-risk stress SPECT myocardial perfusion imaging findings. Hachamovich et al. Followed up 5183 patients after stress MPI for a mean of 2 years and found that the rates of MI and cardiac death did not differ substantially between patients' medical therapy or revascularization after a normal or mildly abnormal scan. However, patients with severe abnormal scans had a significantly higher annualized cardiac death rate when treated medically, 4.6%/year, compared to those referred for revascularization, 1.3%/year, figure 56-3. Patients with a greater ischemic burden on imaging were found to benefit more from revascularization than medical therapy, with serial imaging studies showing a great reduction in reversible defect size in those with revascularization. So, revascularization can be employed selectively in CAD based on the extent and severity of the ischemic burden. Patients with low-risk findings can be treated medically, while more extensive ischemia is best treated with more aggressive interventions. Figure 56-3, SPECT myocardial perfusion imaging and prognosis. This large retrospective analysis of patients undergoing stress SPECT myocardial perfusion imaging demonstrates the incremental prognostic information obtained with the imaging results. The annualized incidence of cardiac death, A, and MI, B, is displayed for patients treated medically, solid columns, and those undergoing revascularization, gray columns, with respect to the myocardial perfusion imaging scan result. Annualized cardiac events were low, 1% in both groups with normal SPECT studies. However, event rates increased with respect to the degree of SPECT abnormality. Survival was significantly improved in those with severely abnormal scans who underwent revascularization. P.01 versus patients undergoing revascularization early after nuclear testing. P.001 within patients treated with medical therapy after nuclear testing. NL, normal. ABNL, abnormal. These principles are shown to impact favorably in terms of both patient outcomes and cost when applied clinically. Several large studies have focused on the clinical utilization of stress MPI to guide patient management and have shown that referral for coronary angio is accordingly low. 3.5% after a normal stress MPI, but increases to 60% when the stress MPI was moderately to severely abnormal. So clinicians can incorporate MPI into their practice appropriately, particularly when deferring further invasive evaluation when the MPI is normal. The use of stress MPI to guide patient management has been demonstrated to be cost-effective. An ischemia-guided approach to managing patients with CAD has been shown to optimize utilization of angiography and subsequent revascularization procedures. The END study compared differences in cost in 11,372 consecutive patients referred for either stress MPI or cardiac catheterization as the initial approach. Not only were the rates of subsequent MI the same in the two groups, costs were significantly higher for the direct cardiac catheterization group as compared to the MPI ischemia-guided approach. Moreover, patients sent directly to cardiac catheterization were more likely to be treated with revascularization in all subsets of risk when compared to those undergoing stress MPI initially. The ischemia-guided approach to stable angina was found to be less costly, with less interventions and similar cardiac events. These cost differences can be directly attributed to a decrease in apparent unnecessary procedures in patients with negative MPI results. Preoperative evaluation for non-cardiac surgery. Perioperative cardiac events are an important cause of morbidity and mortality during and after non-cardiac surgery and occur in greater than 2% of patients undergoing these procedures. Much of this risk can be assessed preoperatively via clinical evaluation, history of CAD or cerebrovascular disease, CHF, renal insufficiency, IDDM, or high-risk surgical procedure, to identify patients at high risk for cardiac complications who might benefit from risk reduction strategies, specific perioperative medical therapy or revascularization, and subjects of sufficiently low risk that further evaluation prior to surgery is not necessary. However, patients with an intermediate risk for cardiac complications may benefit from further non-invasive testing to identify ischemia and provide further risk stratification prior to surgery. Provocative testing for ischemia is typically performed in such patients. However, exercise testing is not always feasible in patients with pulmonary disease or low exercise capacity, and in particular those undergoing orthopedic or vascular surgery. Pharmacological stress myocardial perfusion imaging MPI has been shown to add significant information to preoperative risk stratification. It is recommended for those patients with intermediate clinical risk predictors, prior MI, DM, renal insufficiency, who have poor functional capacity, or those undergoing a high-risk surgical procedure, emergent surgery, aortic or peripheral vascular surgery, prolonged procedures with anticipated large blood loss or volume shifts. When results of stress myocardial perfusion imaging MPI are normal, the incidence of perioperative cardiac events has been shown to be about 1% for all procedures, including major vascular surgery. When abnormal, the severity and extent of ischemia are the most important predictors of adverse cardiac events during and after surgery. Acute coronary syndromes, ACS. Territory at risk and infarct size. Resting myocardial perfusion imaging, MPI, has been used to determine the territory at risk during an ACS and can be used to assess the extent of myocardial salvage achieved with reperfusion strategies. 99-MTC labeled radiopharmaceuticals can be injected at rest in the setting of an acute ST segment elevation MI upon presentation. After initial treatment and stabilization with either pharmacological or mechanical reperfusion, perfusion images can be acquired that represent the initial myocardial area at risk during the coronary occlusion. These images are then compared to those acquired at rest after a subsequent injection after reperfusion. The difference in the size of the defect is the salvage index, initial territory at risk, ultimate scar, between these two scans, which represents the degree of myocardium that was rescued by reperfusion. Although this methodology is not used widely in clinical practice, it is a useful tool in the evaluation of therapies used in the treatment of acute MI. The salvage index has been validated as a surrogate marker of patient outcome and provides a quantitative means to compare the efficacy of therapeutic strategies. The use of the infarct size, territory at risk, and the salvage index have played a central role in trials focusing on the efficacy of primary angioplasty and thrombolysis. His methodology can also assist in determining important clinical factors associated with reperfusion outcome as time to reperfusion and the significance of ECG changes. Myocardial infarct size can be measured quantitatively after MI and has been shown to be highly predictive of outcome. The ischemic burden on cardiac stress SPECT imaging is associated with future non-fatal MI, whereas fixed perfusion defects and a depressed EF are predictive of future cardiac death. Quantification of the infarct size as a percentage of the LV is an effective means to risk stratify a patient's risk for cardiac death over the near term. Studies using 99-MTC SPECT after acute MI have observed that mortality within the subsequent 24 months was about 8% if the infarct encompassed greater than 12 to 14% of the LV. Rest myocardial perfusion imaging, MPI, For acute coronary syndrome, the triage of patients presenting to the ER with acute chest pain is a substantial diagnostic challenge. Radionuclide myocardial perfusion imaging has been shown to have favorable diagnostic and prognostic value in this setting, with an excellent sensitivity to detect acute MI that is not recognized by other testing modalities, serum markers, ECG. A major advantage of a triage protocol that employs REST-SPECT-MPI is that ischemia infarction can be detected earlier than with serum markers. A patient with chest pain and an ECG that is normal or non-diagnostic for ischemia or infarction can be injected in the ER and then imaged within 30 to 60 minutes, figure 56-4. Several observational and randomized studies have repeatedly shown that a normal resting perfusion imaging study has a negative predictive value greater than 99% to exclude MI, and that defects at rest are associated with a higher incidence of death and MI at 30 days. As such, a normal resting myocardial perfusion imaging MPI in a patient with chest pain essentially excludes AMI and is predictive of a sufficiently low risk of near-term adverse cardiac events that the patient can be discharged home. Alternatively, an abnormal study is associated with a worse near-term outcome, and hospitalization is warranted. When semi or unstable angina has been excluded, provocative testing can be performed, with or without MPI, to identify stress-induced ischemia. Protocols that utilize immediate rest MPI to exclude an ACS, and subsequent stress testing to evaluate for significant CAD, have demonstrated both reductions in unnecessary hospitalizations and cost savings compared to routine care. Figure 56-4. REST-SPECT myocardial perfusion imaging during ongoing chest pain in a patient with a normal ECG. Injection of radiotracer during ongoing chest pain and subsequent imaging 45 minutes later demonstrates a moderate-sized area of decreased perfusion in the inferior wall. The patient was brought directly to cardiac catheterization, and coronary angiography demonstrated a 95% stenosis of the RCA that was treated with angioplasty and intracoronary stenting. Post-myocardial infarction risk stratification. Stress myocardial perfusion imaging, MPI, is shown to have excellent diagnostic value in patients after an AMI. Dipyridamole vasodylator stress MPI early after AMI is highly predictive of future cardiac events. Recent studies have found that the most important predictors of future cardiac death and recurrent MI are the extent and severity of degree of the reversible, ischemic, myocardial perfusion defect. Brown et al. Reported the results of a multi-center trial randomized 451 patients after a first AMI to either early, hospital days 2 to 4, dipyridamole stress MPI or routine pre-discharge, hospital days 6 to 12, submaximal exercise myocardial perfusion imaging MPI. The extent and severity of the stress defect and the degree of defect reversibility were found to be the most important predictors of cardiac death and recurrent MI. The early use of pharmacological stress perfusion imaging after AMI was more predictive of early and late cardiac events and provided greater incremental diagnostic and prognostic value than pre-discharge submaximal exercise perfusion imaging. One major advantage of this approach is that management decisions can be made much earlier in the hospital course after an uncomplicated AMI. Assessment of myocardial viability. Left ventricular ejection fraction and prognosis. Numerous studies have demonstrated that LV systolic performance is a powerful and independent predictor of mortality in patients both with and without CAD. When the left ventricular ejection fraction becomes depressed after MI or with chronic IHD, the risk of sudden cardiac death increases substantially. Data from the thrombolysis in MI, TIMI, trials indicated the prognostic significance of left ventricular ejection fraction assessment was also maintained after thrombolysis, although the overall mortality was lower than in the pre-thrombolytic era. The powerful prognostic significance of resting left ventricular ejection fraction assessed by radionuclide angiography is also important in patients treated with thrombolysis or primary angioplasty. Resting left ventricular ejection fraction not only is the strongest predictor of 6-month mortality, but is also predictive of ventricular arrhythmias and sudden death in a similar group of patients. The prognostic significance of left ventricular ejection fraction in patients with chronic CAD is also well established and is independent of the extent of anatomical disease. All of the available techniques used to assess LV function, including nuclear techniques as radionuclide angiography and gated SPECT, as well as 2D echocardiography, contrast ventriculography, and MRI, can provide similar prognostic information in patients with MI and chronic CAD. Radionuclide angiography is the most accurate, widely validated, and reproducible technique, making it a useful tool when serial measurements of left ventricular ejection fraction are required. However, the more widespread utilization of 2D resting echocardiography and gated SPECT-MPI has led to these modalities replacing radionuclide angiography for the assessment of left ventricular ejection fraction. Ejection fraction assessed during gated SPECT stress myocardial perfusion imaging MPI provides incremental prognostic information beyond the perfusion imaging results. In a study of 1680 patients undergoing stress MPI, patients with a gated SPECT left ventricular ejection fraction, 45% had low mortality rates, 1%/year, even when associated with severe perfusion defects. However, patients with left ventricular ejection fraction LVEF less than 45% on gated SPECT had a mortality rate of 9.2%/year, even if only mild-moderate perfusion abnormalities were present. This underscores the importance of left ventricular ejection fraction in determining prognosis and the need to pursue aggressive medical and surgical strategies in patients with depressed LVEF. PET and SPECT in determining myocardial viability. Because left ventricular ejection fraction is a major determinant of survival in patients with IHD, therapeutic strategies that may improve systolic performance and thereby improve survival have been widely studied. Patients with chronic CAD and patients after AMI represent two important groups at risk for the development of LV dysfunction. However, LV systolic dysfunction is not always due to scarring and fibrosis of the myocardium and may be the result of the repetitive and/or chronic myocardial ischemia. As such, LV dysfunction at rest may not necessarily be irreversible. Thus, the evaluation of patients with ischemic cardiomyopathies due to chronic CAD or MI becomes important in order to select which patients might have reversible dysfunction and potentially benefit from coronary revascularization. Ischemic myocardial dysfunction may be produced by four pathophysiological processes. After MI, the myocardium within the vascular territory served by an acutely occluded culprit artery may undergo necrosis and scarring, leading to extensive fibrosis and subsequent regional dysfunction. With an ACS, if myocardial blood flow is restored either spontaneously or with a therapeutic reperfusion strategy as angioplasty or thrombolysis, regional contractile dysfunction may occur even without myocardial necrosis, a state that has been termed stunning. This post-ischemic dysfunction after a transient period of ischemia followed by reperfusion is characterized by normal flow but reduced function in the absence of myocardial scarring. Regional dysfunction may also be observed in chronic CAD, with reductions in blood flow presumably occurring more slowly. The contractile impairment is thought to be due to a compensatory downregulation of function during prolonged periods of myocardial hypoperfusion, a concept termed hibernation. LV dysfunction may also deteriorate due to remodeling, characterized by histological and biochemical changes in the myocardium as a result of an ischemic insult. Myocardial viability was initially defined as the ability to recover global and/or regional LV function after revascularization. In this paradigm, treatment of repetitive or chronic ischemia, defined pathologically as stunning and hibernation, respectively, was deemed responsible for the improvement in contractility. As such, the ability to identify dysfunctional but viable myocardium due to these pathological states became important when considering a patient for potential revascularization. Although recovery of function may be an important goal of revascularization, the central goal of assessing myocardial viability is to predict outcome with therapy, for example, differentiate patients with potentially reversible LV dysfunction whose prognosis may be improved with revascularization from those with large areas of infarct scar who may not benefit, or even do worse, with surgery. Thus, viability assessment provides better insight into the risk, Benefit ratio in patients with ischemic LV dysfunction by effectively stratifying those with a significant amount of viable myocardium who are at increased risk if treated medically from those who would be at high risk with either treatment. At present, there exist a number of diagnostic approaches for assessing myocardial viability in patients with ischemic cardiomyopathy. The major nuclear cardiology modalities to determine viability include techniques that assess cell membrane integrity, regional perfusion, and/or myocardial metabolism. Viability assessments are typically performed in a particular subset of patients, namely those with known CAD and LV systolic dysfunction who are potential candidates for surgical revascularization. Most viability assessment is performed in patients with chronic ischemic cardiomyopathies, or after AMI, since as many as 50% of patients with prior MI will have residual viable myocardium. The methods utilized for viability assessment are similar to those used for prognostic assessment in patients with CAD. As such, protocols used for stress MPI can be easily modified to obtain information regarding viability. However, if the assessment of viability is the principal clinical question, a protocol designed to assess viability specifically should be used. The nuclear cardiology techniques that have been validated extensively in the assessment of myocardial viability include the use of PET imaging of myocardial metabolism, and resting SPECT perfusion imaging of 201 TL and the 99 MTC labeled tracer sestimate and tetraphosmin. Positron emission tomography, PET. PET is generally considered the non-invasive gold standard for viability assessment. PET viability studies involve the determination and comparison of both myocardial blood flow and the metabolic status of the myocardium. Perfusion is usually assessed with 13N labeled NH3, and glucose utilization is typically assessed with FDG, which when taken up by the myocardium reflects glucose transport across the myocyte membrane. FDG accumulates in myocytes in proportion to glucose uptake, but undergoes phosphorylation by hexokinase to FDG6-phosphate in the first step of glycolysis. FDG6-phosphate is a form of deoxyglucose that becomes trapped in the myocyte and is not metabolized further. As such, FDG uptake indirectly reflects exogenous glucose utilization. Normal myocardium preferentially utilizes fatty acids for energy, but switches to increased glucose utilization during periods of ischemia. In myocardial regions with ischemic dysfunction, myocardial glucose uptake may be increased, and thus FDG uptake will be enhanced, reflecting viability. Conversely, FDG will not accumulate in areas of fibrosis or scar. FDG uptake is then compared to resting perfusion imaging. Perfusion metabolism is considered matched if areas of preserved flow show normal metabolic activity, and areas of reduced flow have diminished FDG uptake, SCAR. However, perfusion and metabolism may be discordant or mismatched. In this scenario, FDG uptake will be present in areas of hypoperfusion, indicating that despite decreased blood flow, the myocardium is still metabolically active, hence viable. This mismatched effect is the most predictive of functional recovery after revascularization, Figure 56-5. Figure 56-5, example of a PET viability study. For each panel, perfusion imaging with 13N labeled ammonia uptake is on the left, and metabolic imaging with FDG uptake on the right. The upper row of each panel is the horizontal long axis slice with the apex at the top, and the lower row is a vertical long axis slice with the apex pointing to the left. The yellow and white areas are sites of maximal activity and the blue areas are sites of minimal activity. The red areas indicate intermediate activity. A. Normal images. B. An example of ischemia and viable tissue. C. An example of myocardial scarring. Note the homogeneous uptake of both ammonia and FDG in the normal study. In the presence of ischemia, B, there is a mismatch, arrows, with decreased perfusion and augmented metabolic activity in the apex and the anterior wall. With scarring, C, there is equally decreased uptake of FDG and ammonia in the inferior and lateral walls. A, anterior wall. I, inferior wall. L, lateral wall. S, septum. Quantitative methods. The clinical assessment of myocardial viability using FDG is based predominantly on comparison of its qualitative or semi-quantitative uptake relative to a myocardial perfusion tracer. Quantification of myocardial glucose uptake is possible but requires kinetic modeling of transmembrane transport and phosphorylation to adjust for the behavior of injected FDG in relation to endogenous glucose. Another quantitative approach is the assessment of myocardial glucose utilization, using dynamic PET acquisitions and sequential arterial blood sampling to measure fractional 18F, FDG uptake in relation to the delivered dose. Perhaps of equal importance is the ability of cardiac PET to determine absolute myocardial blood flow using tracer kinetic models. Quantitative myocardial blood flow can be measured with dynamic imaging of 13N labeled ammonia, 82Rb, or H215O. These agents can be used to determine regional myocardial blood flow. Flow can be measured at rest and after pharmacological vasodilation to determine the myocardial blood flow reserve, ratio of maximal flow, resting flow. This coronary flow reserve has been used in the assessment of stenosis severity, flow limitation, in CAD, as well as the evaluation of changes in flow after medical treatment of CAD risk factors such as hyperlipidemia, DM, and smoking. Flow reserve is also useful in differentiating viable from non-viable myocardium, since a certain degree of myocardial blood flow is necessary to maintain myocyte viability. In the setting of a functionally significant coronary artery stenosis, the vasculature distal to the lesion may retain the ability to vasodilate and thus increase regional myocardial blood flow. As such, regions of myocardium that can achieve this must therefore be viable. Flow reserve has been studied as a surrogate for myocardial viability in patients with previous infarction and chronic CAD. Single photon emission computed tomography. Thallium 201TL has been used as a tracer to assess both regional blood flow and myocardial viability. 201TL is actively transported across the myocyte sarcolemmal membrane via the NOPLAS K plasmid base similar to potassium and is extracted from the blood in proportion to myocardial blood flow. Cellular extraction is diminished only when there is irreversible injury to the myocyte, making 201TL an attractive agent for imaging pathophysiological conditions as chronic hypoperfusion and post-ischemic dysfunction. Because retention of 201TL in the myocardium corresponds to cell membrane integrity, regional uptake corresponds to viable myocardium. As such, decreased myocardial uptake early after 201TL injection can be due to reduced regional blood flow or infarction. After injection, 201TL redistributes in the myocardium via continuous exchange between the myocardium and the extracardiac compartments, interstitium, blood pool, driven by the concentration gradient of the tracer and intact myocyte viability. Imaging after redistribution will show less regional heterogeneity of initial 201TL distribution, thereby reducing the relative difference between the ischemic and normal regions. An increase in regional 201TL activity on the redistribution images is indicative of myocardium that has reduced flow but more importantly intact cellular integrity, and thus viability. As such, 201TL redistribution has been used to distinguish viable from scarred myocardium. 201TL can be imaged at rest and again 4 hours later to assess redistribution, or by using another injection if part of a stress myocardial perfusion imaging, MPI, protocol. Viability can also be assessed quantitatively with 201TL. The presence of 201TL uptake greater than 50 to 60% of maximum will be predictive of functional recovery in the majority of segments. Moreover, the final 201TL uptake with redistribution appears to be more important than the degree of change from rest to redistribution in predicting recovery. Technetium label tracers. 99-MTC agents currently are used more commonly than thallium for stress MPI, and these agents can still provide insight into the viability of the myocardium. The ability to determine viability from an initial stress rest MPI study often obviates the need for further testing with PET or thallium protocols. Uptake and retention of the 99-MTC perfusion tracer says to me the and tetraphosphane require that the myocyte cell and mitochondrial membranes be intact. As such, tracer accumulation indicates cellular integrity, and thus reflects cellular viability. Computer-assisted quantitative analysis of regional myocardial uptake of sestamibi has been shown to improve accuracy in predicting functional recovery after revascularization, and similar to 201TL, tracer uptake greater than 50% of peak is suggestive of myocardial viability. The administration of nitrates to enhance resting blood enhanced tracer uptake has also been studied with 99 MTC labeled agents because of issues regarding the underestimation of viability with sestamibi compared to PET imaging. Recently, assessment of metabolism for viability has been performed using SPECT systems with special equipment, high-energy collimators or coincidence detection, or with hybrid SPECT-PET cameras. Prognostic implications of viability assessment. Despite recent advances in medical and antiarrhythmic device therapy for heart failure, patients with ischemic cardiomyopathy and CHF continue to have a poor prognosis. Although many of these patients would benefit from orthotopic heart transplant, donor organ supply is limited. In 2002, with almost 5,000 transplant candidates, just over 2,000 transplants were performed, and 25% of candidates died waiting for a donor organ. With such limited access to transplantation, surgical revascularization is often considered to improve survival in these patients. The selection of appropriate patients for surgical revascularization is largely based on early surgical survival studies that provided insight as to which patients obtained the most benefit from surgical revascularization. The Veterans Administration Cooperative Trial and the Coronary Artery Surgery Study both demonstrated that patients with significant LM or multivessel CAD and depressed EF, 35 to 50% have a better survival with revascularization than medical therapy. Not unexpectedly, these patients often have high perioperative mortality with CABG. Assessment of viability may be useful in these patients to balance the potential benefits of revascularization with the risk of the procedure. The potential to improve ventricular function, and moreover survival, with revascularization necessitates an evaluation for hibernating myocardium in most patients with LV dysfunction, especially those without angina. However, viability testing may not be necessary if the patient has angina pectoris or if initial testing reveals stress-induced ischemia. The clinical endpoints commonly used in viability assessment include recovery of regional or global ventricular function and improvement in symptoms and/or survival. Most studies focusing on the assessment of myocardial viability have employed improvement in ventricular function with revascularization as the clinical endpoint. Although many studies have focused on the ability of viability assessment to predict functional recovery with revascularization, relatively few have used survival and outcomes as an endpoint. The prognostic implications of PET perfusion metabolism mismatch and the presence of viability on imaging with thallium or sestamibi have been demonstrated in several studies. These studies have consistently shown similar findings. Patients with perfusion metabolism mismatch have a very high mortality when managed medically, and much lower mortality if revascularized. Conversely, those with matched effects, indicating SCAR, had no such difference in outcomes between medical and surgical management. Although the methods included a combination of techniques and outcomes used, death, non-fatal MI, unstable angina, need for transplant or revascularization, this distinction is not subtle. Patients with demonstrated viability had an annual event rate of 27% if treated medically compared to 6% in similar patients who underwent revascularization. On the other hand, patients with matched effects suggesting no viability had similar event rates with medical or surgical treatment. This dichotomy in outcomes underscores the prognostic implication of determining viability. A recent meta-analysis pulled data from 24 studies of viability using all currently used techniques encompassing over 3,000 patients further illustrates this point. In patients with ischemic cardiomyopathy, mean left ventricular ejection fraction 32 plus or minus 8%. Those with demonstrated viability had an annual mortality of 3.2% if treated with revascularization and 16% if treated medically. Those without viability had essentially similar outcomes, 7.7 versus 6.2% mortality, respectively. This analysis provides further evidence that the preoperative determination of viability yields important information regarding not only functional recovery, but improvement in survival as well. It is unclear whether the improvement in outcome with revascularization is entirely due to improvement in left ventricular ejection fraction after surgery. A recent study suggests that this may not be necessary. Somati et al. Examined survival after CABG in 104 patients with an assessment of function before and after surgical revascularization. Outcome was similar in patients irrespective of whether the LVEF improved after CABG, suggesting that revascularization of ischemic myocardium, even without improvement in ventricular function, may prevent future infarction and death. Of note, no formal viability assessment was performed in the majority of these patients. Based on studies as these, some have advocated revascularization for all patients with ischemic cardiomyopathy, asserting that hibernating myocardium should be suspected in all patients with CAD and LV dysfunction. However, others maintain that preoperative viability assessment provides an opportunity to balance the potential benefit from surgical revascularization against the risks of the procedure. The currently ongoing surgical treatments for ischemic heart disease, STITCH, trial, a randomized study of medical therapy, surgical revascularization, and/or ventricular restoration, aneurysmectomy, is designed to evaluate the best treatment approach for patients with ischemic cardiomyopathy and heart failure. Evaluation of patients post-revascularization. Despite technical advances, the effectiveness of both percutaneous and surgical revascularization procedures is limited by restenosis and vein graft closure, respectively. Progression of the underlying atherosclerosis or development of new stenoses can cause recurrent ischemia, manifesting as recurrence of symptoms, CHF due to LV dysfunction, MI, or cardiac death. Symptom status is not a reliable predictor of stenosis after coronary angioplasty, as evidenced by up to 25% of subjects having silent ischemia on treadmill testing. However, routine exercise treadmill testing is not currently advocated after coronary angioplasty as it does not reliably detect restenosis. SPECT imaging has been demonstrated to accurately detect restenosis, particularly in the 3 to 9 month window of greatest risk for restenosis, with positive and negative predictive values of 90%. A recent study demonstrated that 201TL stress defect size was predictive of cardiac death and MI even up to 3 years after PTCA. Further study is necessary to evaluate if routine stress MPI after angioplasty indeed alters prognosis, particularly in asymptomatic patients, and in high-risk subsets of patients, decreased LV function, multifascial or proximal lat artery disease, DM, renal failure, after angioplasty. The prognostic value of SPECT-MPI after CABG surgery has been demonstrated in more than 2,000 patients. These studies are summarized in Table 56-1. These reports consistently demonstrate that the finding of reversible defects on stress SPECT-MPI is a strong predictor of worse cardiac outcome in symptomatic subjects early, 1 to 5 years, after CABG, and in all subjects greater than 5 years after surgical revascularization. Future directions. Although the cornerstone of nuclear cardiology has long been perfusion imaging, the field has seen significant advances in terms of new agents that target other biological processes. Interest in the concept of hotspot imaging with tracers that visualize infarction or ischemia has been renewed with the introduction of new radiopharmaceuticals that target these processes in the myocardium. These tracers localize in areas of ischemia or infarction and produce a positive signal for imaging. Examples include glucarate, a metabolite of glucose metabolism that binds to nuclear histones that are exposed in recently damaged myocytes, annexin V, which binds to the plasma membrane of cells undergoing apoptosis, or programmed cell death, and nitroimidazole compounds, which localize in tissues experiencing low O2 tension, ischemia, tumors. Although the clinical experience with these agents is currently limited, these agents hold promise for imaging ACSs in the future. Other molecular-based areas currently under investigation include imaging of atherosclerosis, angiogenesis, plaque vulnerability, and gene expression. Such new approaches will no doubt enhance the future clinical viability of the field. Chapter 56.